I could abbreviate completely the topic by having you read this article. It's a rather recent article by the Toronto group with Andrew Reddington. And I must say, if you read that paper, it is very depressive. It states that nearly all the studies focusing on the right ventricle either showed no beneficial effect whatsoever, or if there was an effect, it was statistically significant, but clinically completely irrelevant, which means that for the clinician, there is still a long ways to go. And so instead of talking about the treatment where the results are rather poor, I will talk more in this talk on how to avoid to get into trouble. Yesterday there was already a talk on how to plan certain procedures. I think with this talk I would like to take it even one step earlier and focus on how to put up your strategy so that you do not get into trouble, because once you get into trouble, as the previous speaker just said, it is very, very hard to get out of trouble. Now, right and left ventricle, there are some differences, and you can compare the right ventricle more or less as a contractile sausage with peristalsis. The fibers are more oriented in two directions, in the left ventricle 3. That means that the contractility of a right ventricle always will be less than left ventricle. We have a difference in valves, and also postnatally, the right ventricle is actually supposed to go in prepension. I mean, it's supposed to work at low pressure, it's more a volume pump, and even if it wouldn't do anything, the left ventricle, through septal interference, will do most of the work in any way. Andrew Reddington provided us very nice PV loops showing that the right ventricle works completely different from the left ventricle, and that already there is an ejection during the pressure increase, and there is still ejection during the pressure decrease. So fundamentally, those ventricles are different. However, if you impose a chronic afterload on the right ventricle, it more or less starts to work like a left ventricle. If you impose a chronic volume overload on the ventricle, it will keep on pumping more like a volume-loaded pump. Here a little intermezzo. What do you think is the value of the right ventricle in normal circulation? Or let me ask you the other question. In athletes, athletes who can increase their cardiac output a 5-fold, what makes it that they cannot increase it 6 times? What is the limiting factor? I think most of you will answer, being cardiologists, and most of your textbook on ventricular function deal on left ventricles, you will answer probably the left ventricle will be the limiting factor, and indeed in disease that's probably true. However, in athletes, and it's more a review that we did write, and I also suggest if you're interested in that subject, we have quite some evidence that it is the right ventricle who is working at a much higher increased afterload that will be limiting the circulation at top performance. And it's interesting to realize that when you start talking about disease. Now, I was supposed to talk about failure of the right ventricle, and you know the right ventricle consists of different things, 2 valves and then the ventricle, and from the ventricle we ask a stroke volume, pressure, and electrical stability. And what does the ventricle has to do? In normal situation, keep right atrial pressure low and provide flow to the pulmonary arteries with stroke volume, pressure, and a certain frequency. And we will start talking about failure if there is any mismatch. However, we all know that that right ventricle, we can see it in different situations, either the normal situation or as a systemic ventricle, and that in very specific conditions. And even this ventricle, the right ventricle in this situation, it can be there either in a parallel, partially unloaded, or heavily unloaded situation. At the end of the talk, I hope that you will understand that chronic unloading can be as detrimental as chronic overloading. The tricuspid valve I will not talk too much about it. That's a specific point by itself, and I think most of you will agree that medical treatment over there is no big issue. Also, when we talk about stroke volume, we know that the ventricle has some requirements, and if the stroke volume is not good enough, there will be right to left shunting, there will be cyanosis, and that cyanosis can be regarded as ventricular failure. However, there is no medication that can treat this. I like to show this slide. It's from 1971. It's actually from my professor, Luc van der Houwaard, who just around the time that Fontaine described his patient, also described a similar thing in a bipartite ventricle where he closed with a balloon an ASD and showed that the flow could increase, and this patient has been doing good for about 30 years, showing that indeed the atrium and the atrial kick, which is huge in this patient, can be transported to the pulmonary artery, and that's a way of treating small stroke volume. Again, we don't have a drug for this. What if there is a pressure problem? Well, there can be mechanical problems, especially with what is called the Windkessel phenomenon, and it's something that we do see in congenital heart disease when you use not as much homograph, but let's say the thinner conduits, like for instance a Contegra, which can be, if there's a stenosis at the pulmonary arteries, which can greatly enlarge, and then the right ventricle will just squeeze blood into that system and it will go more up and down instead of having effective ejection into the pulmonary system. Or also the myocardium can be failing, and then either that can be because of primary reasons or secondary reasons. Allow me to quickly go over that. Uhl's disease, extremely rare, but again, I think everybody that has ever seen it will know that medication is of very, very limited value. Electrical stability in the heart is very important, and as a matter of fact, as you will see, a lot of the mortality we have in right ventricular overloaded ventricles is electrical. So avoidance of electrical problems is very important. There can be primary automaticity. However, I will focus now on the next couple of slides on these issues here. This is a study we did a couple of years ago on Belgian bikers. Belgium has good bikers, we have nice hills, but you have some fanatics in Belgium that will sit on their bike for 2 to 4 hours a day, and they will bike about 600 to 1,000 kilometers a week. If you do that for about 15 years, what do you see that happens? Well, some of them will drop dead. Sudden death in athletes is a known phenomenon, but they must be seriously trained. Now, what did we look at in those patients? Well, we looked at non-athletes that had normal heart, so no ventricular arrhythmia. Athletes, well trained, we're talking about triathlon runners also and bikers, who had big ventricles, normal stroke volume, but then the athletes that did have ventricular arrhythmia, their ventricles were slightly bigger, but if we looked at contractility, we saw that their contractility was way down. What is the lesson that you can learn from that? If you sit on a bike for about 15 years, doing about 1,000 kilometers a week, you burn out, you destroy your ventricle, you become vulnerable for ventricular arrhythmia. Now you're going to say, what does this mean for congenital heart disease? Well, don't forget, if we ask the surgeon to operate on a fallow patient and he puts in a transaminal patch, that patient will have a chronic volume load 24 hours a day, and indeed, what do we see after 2 to 3 decades? We see an increased incidence of sudden death in those patients. So there will be probably some similarities that we have to acknowledge. The history is also known in pulmonary regurgitation. Pure pulmonary regurgitation, it's already known for a long time, is not well tolerated. And here, this is the worst case scenario after early repair of tetralogy of Fallot, leaving the patient with chronic severe pulmonary regurgitation. This is the worst picture I can have from our database in about 1,200 patients now. I think most of you will agree that if you get to that stage, the effect of medication will be extremely limited. Also, if your patient comes in like this, first of all, the patient would be already happy that he gets to the emergency department with this treatment. But again, the optimal treatment for these patients nowadays is this, and I think most authors will agree that medication in these circumstances will be very limited. The key issue will be how to avoid this situation, how to get out of that. And there we have to always look, what do guidelines say, and what is the value of guidelines, how valid are they, and how true are they, or how detrimental can they be? If I can remind you, in the 1980s, the surgeons did learn that leaving a moderate to a severe degree of obstruction in a fallow was deadly. So what they found out was, if they did put a big patch across the pulmonary valve, taking away all the obstruction and leaving regurgitation, their mortality came way down. So in the 80s, the kratom was accept any degree of pulmonary regurgitation, as long as you don't leave stenosis. And for quite a few years, 2-3 decades, that was indeed what was being done. However, in the 1990s, we did learn that PR was detrimental, and then that you needed a valve in that position. And still now we are discussing pulmonary regurgitation, how much is too much and how long is too long. A lot of centers, and yesterday it was discussed briefly, have mentioned criteria of how far you can go. And so this magic number of 150 to 170, depending on the center, with some additional criteria, what do these guidelines predict? Well, they predict some recuperation of RV function if you allow the ventricle to evolve up to that point. Now, is this what our patients are asking us, that they have a right ventricle that can regress? Well, my patients, they ask me, please give me the comfort of having a good life, reach my 70s or my 80s, and have the heart not as being a limiting factor, nor for quality nor for quantity of my life. That's what my patients ask. Now, that is very difficult for us to answer. So we have put surrogates in there, and we talk about function, and we think that the function will do it, but that's not the key question. What we do know is that if you leave significant pulmonary regurgitation, that ventricular function will go down, and somewhere in the second, third decade, we reach the red zone where ventricular arrhythmia will occur. Early in the 90s, when we realized that, revalvulation was offered on those patients around that period, when they became symptomatic. We know that the grafts didn't, the conduits that were inserted then gave another 10 to 20 years, something like that, but it is still a far away from where we wanted to go. We have learned then in the late 90s to do that earlier. And so if you do it earlier, you get a better regression of your dysfunction. You get some recuperation. But again, the valves, the conduits we have, do not last a long time. But now we're able maybe to reach the 60s and the 70s, taking into account one operation here, second, third, fourth, fifth. Well, most surgeons will thank for the sixth operation. We now have percutaneous valves, so we can alter this graph a little bit, and after the first homograft, as we see that it starts to deteriorate, it doesn't have to go down that much the drain. We can revalvulate over here, but those valves won't last forever, but we can put another one, and now we get the 60s to the 70s with only 3 operations, already much better. And lately, we have been revalvulating these patients even earlier, without first introducing a homograft. If you revalvulate there, I must say I'm very much impressed how close you can get to normality. And these valves, we only are sure about these data where, it stays, the valve function stays very well for quite a few years. This is predicted, but we'll see. Now the key question is, will our patients will be happy enough reaching this area, or will this over here be good enough, especially what ventricular arrhythmia is concerned? And there we have to say that we don't know the answer. So with the the current strategy adapted by most patients, with conduit over here and then 1 or 2 revalvulations percutaneously, we probably will end up over here. With the strategy I'm just talking about and revalvulating over here, I hope, it looks like, we might get better. Nothing is proven yet. This strategy, for sure, is not being proven to be superior. However, we have to remind that this strategy neither has been proven to be valid up to the 6th, 7th decade, and that is exactly what our patients are asking us to do, not 20 years survival. Now, another very important topic is chronic deprivation, and that is something we see a lot in mustards and fontans. Now, the literature about chronic deprivation is very scarce, and so if there is a third article I can recommend you to read once, is an article from Liu from China from 1992 in Circulation. Very, very nice paper. But what did they show? They looked at patients with severe mitral stenosis. And so here is a normal filling pressure of a left ventricle, here of a ventricle that is chronically unloaded by mitral stenosis. What did they do in those patients? Balloon dilation of the mitral valve. So they just opened up the valve, no more than that. And what did they see? Not immediately, but after half an hour, that ventricle came from this curve within half an hour to this curve. This means that chronic deprivation stiffens up your ventricle. If you give it more preload, it will squeeze better. Now, don't forget, the previous speaker one of his big problems was ventricular dysfunction in a fontan circuit. It's the chronically deprived ventricle. But there you get with the major problem. How do you increase a preload in a fontan ventricle? So what we can learn from all these studies is, if this is your the part of the pressure volume curve in a normal ventricle, when we give acute overload as with an early neonatal shunt, that is what's going to happen in the filling pressures. If it persists for a couple of months, typically what we will do, that's what it's going to look like. If it's too much, we will burn out the ventricle, but then at the time of a fontan, we will underload it, and if it's severely underloaded, the ventricle will stiffen up. You will increase your pressures, and the higher the ventricular filling pressure, the higher a fontan pressure. Is medication going to change that? Well, there is not a single drug that has the capacity to change anything of this. We may also not forget the ventricle has a big story, both here now very specifically for the fontans. If this is a pressure volume loop of a normal ventricle, well, this will be the right ventricle in a hypoplastic left heart. He has to squeeze for both ventricles. And in the early neonatal period, he will have to do the shunt as well. So this is now the pressure volume loop of the right ventricle at the end of his shunted stage. Then we will unload the ventricle, and if it's a poor failing fontan, what do we see? Stroke volume comes down enormously, filling pressures will increase. Exactly the things we don't want to see. But that is basic history of the ventricle. And now, indeed, we have to ask ourselves, do you call this now a dilated ventricle because this is what we call normal, and this is what we see in that right ventricle in a hypoplastic left heart? Or, knowing that it comes from this situation, shall we call this ventricle now overgrown and deprived? It does influence enormously the way we think. But ventricular dysfunction, in the right ventricle in ventricular dysfunction, in a fontan, predominant will be dominated by how much flow gets through the lungs in the first place. So there we have to look at how does the lungs look like. And again, the previous speaker just showed a very nice slide that pulmonary arteries after the Glenn or after the fontan operation show very little growth. So that means, when do pulmonary arteries grow in a single ventricle? Well, this is the pulmonary flow in those patients. During fetal life, very little. And then in the neonatal period, they will get their shunt. And at the time when the Glenn will happen, and also at the time of the fontan will increase slightly the flow. Flow will increase, but it will remain subnormal. This means that the only catch-up growth, or the decent growth that you will get from for a univentricular heart, is in this period. But it is this flow that will determine the preload to the ventricle, especially in the hypoplastic left heart. And I will show you in a few minutes that the right heart doesn't like at all the chronic underloading. Now, what if something goes wrong in the neonatal period? The The preload, I mean the growth factor, the growth inducer for pulmonary growth will be very little. This patient will become blue early. If then you go to the Glen, surviving the Glen is no big issue. Everybody knows that. But if you take that then to the fontan, you end up with a bad fontan, low flow, and we know the bad fontans, they have a declining result and they will die over here. This bad result is actually caused by a poor intervention or a poor result over there. So it may be worthwhile at the moment you decide about what to do when this first shunt procedure becomes too small, you might consider augmenting that shunt either way by getting another go for pulmonary growth, and this growth may induce then a better result at this point. Again, so we have to think quite ahead when dealing with ventricular dysfunction in some of these rare diseases. What if the right ventricle is a systemic ventricle? Again, quite a few circumstances. And we know that this right ventricle can become very hypertrophic. The tricuspid valve, because of its specific features and septal adhesions, will be pulled open and tricuspid regurgitation will significantly increase. It can be countered if this is now in double discordance, the function of RV and LV. So LV immediately after birth can go on prepunction because it only has to work in subpulmonary system. And we hope, and sometimes indeed we do see that patients with double discordance may have good, reasonable RV function until old age. However, most frequently we will see something like this, where RV dysfunction will occur in the second and third decade. Do we have decent medication that will alter this, this evolution? To be very honest, no, we don't. ACE inhibitors have very little effect, if any. Diuretics, beta blockers, aldosterone, in this situation are very little importance. Again, it's something that we have been working on is working on the banding of the pulmonary artery, where in this situation, increased pressure in the ventricle will allow the left ventricle to help the right ventricle. And indeed, we see that patients with double discordance and pulmonary stenosis do better than those without pulmonary stenosis. So we can create it and see what happens. The philosophy over there is that the afterload for the left ventricle is increased by the band. You allow the patient to grow into the band, and you hope that RV function, after you see the initial decline, can recuperate. And of course, this is wishful thinking, but that's what we hope for. So this is now my last slide. What about the treatment of failing right ventricle in congenital heart disease? I think the key issue is avoidance. You have to avoid acute and chronic pressure overload. Just think about leaving a residual coarctation in a hypoplastic left heart. You burn out the right ventricle within a couple of weeks. And once it's lost, it's lost. Avoidance is the issue. Avoid a chronic volume overload. We all have seen those right ventricles with a big VSD in double discordance. If you allow the ventricle to expand too much, you burn out the ventricle, you destroy the tricuspid valve. However, the point I also wanted to make today was underloading. Think what happens in the pathways of a mustard. They chronically underload the systemic ventricle. The right ventricle in a fontan, it's chronically underloaded. The right ventricle doesn't like that at all. How to treat it? It was actually my topic, but it would have been one negative study after the others. Even more, we don't know the markers we have to obey, when to start. We think we have some guidelines, but those guidelines by far are not very, have not proven that our patients will reach old age. And also the targets that we have to go for are ill-defined. This definitely is not the medical way of treating, but as Stanislav said, as a previous speaker, in quite a few circumstances, heart transplantation or mechanical assist will be the only solution to help these patients. Most drugs, I mean, the good drug hasn't been invented yet, I think. Thank you for your attention.